Hi, everyone. My name is Vincenzo Berghella, and it's a pleasure to welcome you to another edition of Live at AJOG MFM. Today, we have the pleasure to have an esteemed panel here to talk about twins. I'm very excited about this session today. Should be fantastic. I want to remind you before we start that we did already 5 live at AJOG MFM about what's going on at AJOG MFM, then on manual rotations, then on randomized controlled trials, also on COVID vaccine acceptance in pregnancy and on the use of ultrasound in labor. So these are 6 such sessions. Thank you for being so many watching us. It's been a great success, and we look forward to do them continue to do them in the next few weeks and months and years. If you want to have any questions, I want to remind you, not only you can watch from our AJOG MFM Twitter and YouTube account, and from my Facebook, Twitter, and YouTube account, as you see listed in the slide, but you can also ask questions on those accounts. With that, I will disappear, and I will pass it on to John Barrett and his team, who have a wonderful program ready for us. John.
Vincenzo, thank you very much. And thank you very much, everybody out there, for tuning. And I hope you're here because I really have been in this field for a long time, as many of you will know, but I can't think of any event in which we've been able to get the world expert in twins available at one time. And I think this is all kudos to Vincenzo and his team at AJOG MFM. Maybe I'm biased. I think it's probably the best journal in the world right now, and everyone should support it. I think it's fantastic, and these novel ways of letting people get X together is just fantastic. Many of the people that you see, I mean, we can show the picture of the people you can see, and everybody. I mean, you should know everybody on these pictures. This, as I say, the world's expert, and we're going to be hearing from many, if not all. You can see. I'll introduce them as we go through, but Liran Hirsch, Elizabeth Louis, Tim Van Meen, Mark Evans, who's one of my mentors. I followed him since I was a fellow, and it's just a pleasure to be on board with him. On Mark. Amanda Roman, your work on twins and cervical cerclage is shaking the world. And last but not least, who was my fellow, but now who's responsible for a lot of the edition. It's just a pleasure. Amir, thank you. Congratulations for all of you doing that. So really, it's been great. And Vincenzo, it's all because of you. So without further ado, we haven't got a lot of time. I'm going to introduce our first speaker, Dr. Liran Hirsch. He might be a professor by now. If not, he should be. Again, one of our fellows who came to spend time with us in Toronto and who taught me more than I know, who's going to talk about dichorionic diamniotic twins. He's now division head, maternal fetal medicine at the List Maternity Women's Hospital in Tel Aviv, in Soroka Hospital Medical Center in Tel Aviv. Associate professor, he says, okay, we have to change that soon, Liran, and at the Sackley University Tel Aviv. So Liran, tell us about dichorionic twins. We're going to let everybody talk, and then we're going to have some roundtable at the end rather than interrupt. And so everybody stay tuned. If you've got friends who aren't listening, send them the links. And Liran, over to you.
So thank you, John, for the welcoming events, and thank you, Vincenzo, for organizing all of that, and especially for letting me part of this amazing team and amazing project about twins. So in my 5 minutes, because we have very, very interesting evening, but I don't take too much time. So I'll talk about points from our review about the antenatal care in dichorionic diamniotic twins. So I would like to thank my associate that helped me and joined me in this manuscript, Dr. Atali from my hospital, and especially Dr. Melamed, which is not here on this event, but is one of my mentors, together with John and many others here. And I think that the main message of our manuscript is that twins are not just 2 babies at the same time. I think this is the main thing we need to remember, because when you look about the perinatal complications and the rate of complications, when you talk about twins, we can see that even in singleton, if you look about hypertension, the complication of pregnancy, In singleton, it's about 35%, but in twins, it's not just doubled, it's much more. And you can say that also about preterm birth, especially the early preterm birth, again, very high rate of perinatal complication there. And even if we take a low birth rate or even SGA pregnancies, you see that the rates in twins are much higher as compared to singleton, and it's not just doubled, as you say, if it's going to be just two babies at the same time. So I think this is the main message of our manuscript. The second message that we want to acknowledge is the importance of the first antenatal visit. It's true for all pregnancy that we need to elaborate more and deal with the patient education and review the antenatal care plan. But here in twins, because the physiology and the pathologies in twins pregnancy are much higher as compared to singleton, we must pay attention to this visit. It should be dealt very with caution, because the couples or the mothers to be are sometimes excited, but sometimes they're afraid of this new thing that they are going to, and this is maybe a fearful event. Some are used to antenatal care, which is very basic, and now they will ask to be very well follow up with many antenatal care, maybe more tests, more ultrasound exam. This can be exhausting but frightening as well. So everything needs to be done very carefully and upfront. In addition to that, of course, there's technical issues that are very important in twins pregnancy, like dating the pregnancy and determine the chronicity, because this is the basic of the antenatal care in twins in general. The third part of the manuscript, I think, if you want to think about the take-home messages, is the special considerations in twins pregnancy about different situations that my colleagues here will further elaborate. One of them will be the genetic screening and testing that should be done in pregnancy, and Dr. Hopkins will probably elaborate more, but there are differences maybe in the management of twin pregnancy difficulties, and we will see that the guidelines are very not uniform and very maybe confusing. Some say to prefer this kind of test, some say maybe do the other one. This is also true for the preterm birth screening and prevention, and I think that Amanda will elaborate about that. What should we do about that? Can we prevent or preterm birth in twins? Are there any modalities for that? There's the new progesterone study and meta-analysis, and there is the RCT of Amanda regarding the cerclage. And should we do cervical screening, yes or no? And finally, I think one of the main issues related to twins, but also in dichorionic twins, not only monochorionic twins, is the fact that the growth in twins is a bit different, especially in the third trimester. But when you look at guidelines, and these are only, I think something is wrong with the slides, but if we want to look at the guidelines and we think about the different guidelines that we have about twins, we see that not all of them are so well dated, and there's discrepancy about the recommendation. For example, if we talk about prenatal diagnostic of aneuploidy, some say that CVS should be preferable, some have no specific recommendation, some say that you can use either amnio or CVS for this instance. And when you talk about cervical F screening, so some say you should do cervical F screening in twins, some say it doesn't work, some say insufficient data. So we can see that there's no good data and clear data about this issue. And when we look at the guidelines, you can be a bit confused. So this is another thing. We need to explore more. We need to try to get more data, and maybe we need to find uniform guidelines and see what's the best way. And of course, when we talk about the growth in twins, this is something that I'm really into it in the last few months or years, is the fact that we know that twins are grow differently, especially in the third trimester. You can see here, just for example, the NICHD twins curves as compared to the headlock, which is singleton curve, to see the difference between them. And really, there's a big debate. What should we use? Should we use twin-specific chart or singleton charts? And I have several colleagues, including John here, that recently published a review that I think it's very interesting about this topic and can shed some of the dilemmas about this topic. So really, because I think I'm out of time, the three take-home messages from our review is that twin pregnancy are not just two fetuses sharing the room in the uterus at the same time, the importance of the first antenatal visit, and of course, there's many gray zones and lack of uniform guidelines is something that we should keep in mind, and maybe as different societies around the world will try to embrace and maybe get something into it and maybe try to be a bit more uniform. Thank you, everybody.
Liran, Todaraba, thank you for that. A good introduction to the field. And now, Goedemiddag, Lisbeth. It's good to see you. Welcome. I think you're back in Belgium, unfortunately. We had some lovely time in Toronto. Lisbeth, you're going to talk to us, and I can't think of anybody better. I think monochorionic diamniotic twins and aspects of that. And everyone keep your questions, write them down, and we'll have time, because everyone's going to keep to time. We'll have time to address these aspects as we come back. So thanks very much, Liran. Elizabeth.
So thank you very much to the organizing committee for inviting me from Belgium to talk to you about monochorionic diamniotic twin pregnancies. So I'm going to highlight the most important things of my paper that has been published in the American Journal in Fetal Maternal Medicine. So importantly, the majority of twins are dichorionic, 80%, and 90% of these are dizygotic, but 20%, about 1 in 5 twins are monochorionic diamniotic. And these are, by definition, always monozygotic. And we need to make the diagnosis on the first trimester scan. And you just have to be able to count to 3. So in dichorionic twins, you have the thick chorionic layer, and on each side 2 thin amniotic layers, whereas in monochorionic diamniotic twins, you only have the 2 thin amniotic layers that separate the twins. And the distinction is very important because we know that the monochorionic twins, they have a 3 times higher risk of fetal loss, also higher risk of neonatal demise, and their overall survival is almost 10% lower than dichorionic twins. And also they have an increased risk of developmental delay, and also the risk of cerebral palsy is 4 times higher in monochorionic twins as compared to dichorionic twins. And the excess mortality and morbidity in monochorionic twins is largely explained by the shared circulation. So monochorionic twins, 95% of these twin pairs have vascular connections that connect the fetal circulation. And we know that in about 15% imbalances will occur during the intrauterine life. Now, the most important transfusion imbalance in monochorionic diamniotic twins is twin-twin transfusion syndrome. It's a difference in amniotic fluid, and it occurs typically in the pre-viable period, and about 1 in 10 monochorionic diamniotic twins will develop TTTS. And we screen for TTTS by a biweekly or an ultrasound scan every 2 weeks in all monochorionic twins. And you don't need to be an expert sonographer. The diagnosis is made by measuring the deepest vertical pocket. And so in the donor baby, they should be less than 2 centimeters with a small or empty bladder, whereas in the recipient twin in the States, you use more than 8 centimeters with a distended bladder throughout pregnancy. But just to mention that in Europe, we use gestational age-dependent criteria. And TTTS is the most common reason why we lose monochorionic twins or why they sustain long-term handicap. The other transfusion imbalance next to TTTS that can occur in monochorionic twins is called TAPS. It's twin anemia polycythemia sequence, and it's less common than TTTS. So it occurs in about 1 in 20 monochorionic twins and usually in the viable period. And in contrast also to TTTS, it's not characterized by a difference in amniotic fluid, but by a difference in hemoglobin levels between the twins. And in Europe, most centers already screen for TAPS by measuring the middle cerebral artery peak systolic velocity, where in the donor baby, there will be increased velocities, and in the polycythemic recipient baby, there will be decreased velocities. But also there are giveaways on your ultrasound scan that suggest TAPS. You have the congested liver, which we call the starry sky aspect in the polycythemic recipient baby, and also what we call the placental dichotomy with the white thickened part in the anemic donor and the dark thin part in the polycythemic recipient twin. Another common complication in monochorionic diamniotic twins is when there is a significant difference in estimated fetal weight, and in clinical practice we use more than 20% difference in size between the babies, and that occurs commonly. It's about 1 in 5 monochorionic diamniotic twins that have this significant difference in size in the absence of TTTS and TAPS. And we classify selective fetal growth restriction in monochorionic twins based on the umbilical artery pattern in the smaller baby. And most selective fetal growth restriction cases have a positive end-diastolic flow in the umbilical artery. So 15% of monochorionic diamniotic twins have what we call type 1 selective fetal growth restriction. And in a minority, there is a continuous absent or reversed end-diastolic flow, or an intermittent absent or reversed end-diastolic flow. This is typical for monochorionic diamniotic twins, and these cases have large artery-to-artery anastomosis that cause this cyclical pattern. And that's also the reason why we recommend to sample the umbilical cord in all monochorionic twins at the cord root in order not to miss the presence of this cyclical variation. Obviously, these rare cases where there is an abnormal flow pattern in the smaller baby have an increased risk of perinatal morbidity and mortality, whereas if the flow is normal in the smaller baby, they do as good as uncomplicated monochorionic twins. And then finally, important, 1 in 10 monochorionic twin pair, there is an anomaly in one baby. So although they are monozygotic, usually only one baby is affected. And I just want to highlight that discordances in chromosomal abnormalities do occur in monochorionic monozygotic twin, and often there is discordancy for Turner syndrome in these cases. And also structural anomalies occur, and we know that in about 50% of cases, the anomaly is already detected in the first trimester. And the typical unique complication or anomalies in monochorionic twins like acardiac twinning or conjoint twinning are also readily detected on the first trimester scan. Obviously, monochorionic twins can also have acquired anomalies. The right ventricular outflow tract obstruction in TTTS, or because of laser treatment, amniotic band syndrome, or cerebral hemorrhages when there's severe anemia in TAPS. So just to highlight that in monochorionic twins, you need to screen for anomalies throughout pregnancies. So that's what I wanted to talk to you in these 5 minutes. I hope you enjoyed my talk, and I also hope you enjoy reading my review. Thank you very much for your attention.
Wonderful. Thank you for doing that in such short time and being so so comprehensive. I really enjoyed that, and really enjoyed having you in Toronto, Elizabeth. We miss you, but you did leave behind somebody from Belgium with us. Maybe he preceded you, I'm not sure, who has made such a difference to fetal therapy here in Toronto, and is leading us with that. So, Tim, you're going to sort of follow on naturally, I think, with aspects related to twin transfusion. Thank you, Tim.
Thank you very much, John, and thank you, Amir, for making me part of this nice journal and of this nice review series. So my talk and the paper were about monoamniotic twins, so a very specific subtype of monochorionic twins. Monoamniotic twins are very rare and only occur in about 1 in 8,000 pregnancies, but they're really important to recognize because they go with high perinatal and prenatal risks. We do know that the embryo in monoamniotic twins splits late in pregnancy, and that can be associated with problems. We do know that in monoamniotic twins, the 2 fetuses share 1 placenta, which can bring problems of its own. And we do know that they share 1 amniotic cavity, which can allow the cords to get entangled, which brings specific problems associated with that. And really, in this paper, we're trying to highlight all these problems that can occur and tell you how to manage these twins properly. Now, the very first important thing is to recognize them, because before you can really treat a pregnancy or manage a pregnancy differently, you need to know what you're dealing with. And so this here is a typical picture of a monochorionic diamniotic pregnancy, where the two fetuses are separated by their own amniotic sacs. This here is a monoamniotic pregnancy, where you see that the two fetuses already in the first trimester are in one single sac. And this is a very specific subtype of monoamniotic twins. And these are conjoined twins who have even body parts in as a shared medium. Now, recognizing monochorionic diamniotic twins really needs to happen in the first trimester, because it's really difficult to differentiate the thin membrane and recognize the chorion later in the pregnancy. In monoamniotic twins, the timing of the diagnosis is a little bit less critical, because you will see the cord entanglement in that shared amniotic cavity all throughout pregnancy. But nevertheless, it remains really important to recognize them early so that you can start managing them properly. And one of the first big problems that we see is, as I said, splitting related problems. And in a monoamniotic pregnancy, the single egg and sperm cell come together, form a single embryo initially, and that then splits later on, typically somewhere between day 9 and 13 of pregnancy. And so when that splitting happens late, the twins may have more shared elements, and that results in a much higher risk of fetal abnormalities. And we know that in monoamniotic pregnancies, the risk of fetal abnormalities can be as high as 20%. The second problem that I said was that they have a shared placenta, and you already saw a beautifully injected placenta presented by Lisbeth Lewy earlier. And this is another monochorionic placenta in a monoamniotic twin pair. And what you can see here is that the umbilical cords typically in these twins are very closely together. They have massive overlapping placental territories, which allows huge connecting anastomosis between the fetuses. And so that allows significant volume shifts, but also compensates for a few things. And so, for example, conditions like twin-twin transfusion syndrome and selective intrauterine growth restriction, which is due to unequal placental sharing, are much less common in monoamniotic twins than in monochorionic diamniotic twins. Twin-twin transfusion syndrome will only be seen in 2 to 4% of these pregnancies, and severe discordant growth only in 7%, so roughly half of what is seen in monochorionic diamniotic twins. This placental vascular pattern also sets these twins up for a unique complication that is seen in monochorionic twin pregnancies, which is acardiac twinning, or twin reversed perfusion sequence, trap sequence, where one fetus does not have a heartbeat anymore and is basically perfused through these large blood vessel connections on the placenta by the healthy fetus. Again, something that needs to be recognized timely so that it can be treated before the acardiac fetus starts compromising the healthy fetus. And then finally, I said these twins are in a single cavity, so they have the risk of cord entanglement. And this is a picture of a recent case that we had, where you can see how the cords are tightly interrelated. And the problem with the cord entanglement is that they can sometimes form tight knots, which can cause one or both of the fetuses to die before birth. And if you look at all monoamniotic twins, the risk of fetal death is probably somewhere in the range of about 30%. Part of this is due to structural fetal abnormalities, but in otherwise uncomplicated monoamniotic twins, the risk of cord-related fetal death is still about 15%. Before viability, we don't have much of a backup plan for this, but after viability, we can technically deliver these fetuses if we see the fetal death being announced by ultrasound findings or fetal heart rate tracing abnormalities. So typically, we recommend to monitor these pregnancies much more intensely after viability. Typically, we would do that at least 3 times a week. The question then is, where should these pregnancies be followed and monitored? I think it's very obvious that all these pregnancies should be looked after in expert centers that have significant experience with monochorionic twinning. And then after viability, there is still some discussion about whether you should admit all these patients for intensive fetal monitoring or whether you can do this on an outpatient basis. One recent systematic review of the literature, which was published in the White Journal, showed that the mortality is possibly, or the fetal mortality is possibly a little bit lower in patients that are managed as inpatients compared to outpatients. Now, the problem with this systematic review is that it really did not analyze the timing of the deaths in these pregnancies very closely. And I've just brought in this graph brought up the two main studies that determined the systematic review. So the first study that you see here in A is the mono study. That was an international multi-center study looking at location of surveillance and looking at the risk of fetal death. And so in this study, pregnancies, uncomplicated monoamniotic twin pregnancies were either managed as inpatients, and that was done in 75 pregnancies. And these patients had very close surveillance as inpatients from 26 weeks onwards, and were then delivered somewhere between 32 and 35 weeks of pregnancy. And then there was an outpatient cohort of about 120 pregnancies that were managed as outpatients, had close ultrasound surveillance, and were then delivered at 32 to 35 weeks. And the study said the risk of fetal death, which is here represented by the red crosses, is much higher in the outpatient group than in the inpatient group. And that was accurately so. Now, the big difference between those two groups was that the outpatients only underwent close surveillance after 30 to 31 weeks, whereas the inpatients underwent close surveillance from 26 weeks onwards. And you can see that all the deaths basically happened before close surveillance was ongoing. Similar results were seen in a study that I managed in collaboration with different centers internationally in Europe and in the US, showing again that when you look at outpatient or inpatient surveillance, that the risk of fetal death was slightly higher in the outpatient cohort. But again, the fetal deaths in this group happened before surveillance was instituted. So if you put everything really together, and if you only look at the duration of the surveillance, then the risk of fetal death in both groups during ongoing surveillance is probably very similar. So how do we manage these twins, and how would I recommend to manage monoamniotic twins? Well, typically we start with a dating ultrasound around 10 weeks of pregnancy, at which time the chronicity and the amnionicity should be determined. That can then be confirmed at 12 weeks. At that time, aneuploidy screening can also happen, and you can start aspirin for preeclampsia prevention if that is something that your center supports. We offer these pregnancies an early anatomy ultrasound also around that time to diagnose the more major structural abnormalities. We then follow them every other week with ultrasound to look for severe growth discordance or twin-twin transfusion syndrome. A formal anatomy ultrasound and echocardiogram is done at 20 weeks. Then again, ultrasounds every other week. And then between 24 and 28 weeks, we typically sit the parents down with our NICU team to discuss about viability and preterm delivery. The steroids are administered for lung maturation, and then we manage these patients with very close surveillance, either as inpatients or as outpatients, based on patient preference, with ultrasounds at least 3 times a week, and fetal heart rate monitoring in an outpatient setting 3 times a week, and 2 times a day in an inpatient setting. And we then deliver all these pregnancies by cesarean section at 33 weeks of pregnancy. So what I want you to remember is that monoamniotic twins are really very high-risk pregnancies. I think there is very few comparable situations in obstetrics. The survival is only about 70% for these twins, but with close surveillance, you can decrease the risk of fetal death after viability, and you should aim for delivery at 33 weeks. Thank you very much.
Wonderful. Thank you, Tim. I think I forgot to tell him, I just assumed everybody knew where you worked. So Tim works at Mount Sinai Hospital at a center called the Ontario Fetal Center, which is responsible for advanced fetal therapy for much of Canada. And so, Tim, thank you for that lovely talk. So next, Mark Evans, who truly shouldn't need any introduction to anybody watching. Mark is so well known across the world for his work on fetal reduction. He works in Comprehensive Genetics and Fetal Medicine Foundation in New York at the Icahn School of Medicine. It's a pleasure to have you on faculty here, Mark, and want to hear your thoughts on fetal reduction as disposed in this field of twins. Thank you, Mark.
John, thank you so much. It's a pleasure to be here with all my friends and to participate in this seminar. The incidence of twins has gone dramatically up since the infertility era. It has begun to plateau. But if you see a woman sitting, having a cup of coffee with a twin stroller, the chance that she got pregnant with help is still about 65%. And in fact, as Tim has just described, and Elizabeth before that, these often do not do well. They basically have a much higher complication rate, and fundamentally the risk of twins is not twice that of a singleton, but really it's about 4 times that of a singleton. So what are our options? Well, back in the 80s, when I was one of a few people who helped basically invent fetal reduction, we had no data, but I felt we needed to have some guidelines. So I worked together with John Fletcher, who was the bioethicist at the NIH, and we decided back then that we would not reduce below twins, except in extremis. And the rationale was every OB could handle twins. The outcome was reasonably close to a singleton, and particularly since the fertility therapies were so terrible and we could never be certain of getting the woman pregnant again, we really didn't see a reason to do it except if there was a problem. Most of these patients were infertility. Most had no children, and it would get them closer to their family planning desires. We also didn't know what the risks of further reduction would be if we went from 3 down to 1 or 4 down to 1, and therefore it just didn't feel ethically justified. Well, of course, there always were exceptions. The woman who was a dwarf, the woman who had cardiac disease, the woman who had a uterine abnormality and a fetal abnormality. And what we found when we looked at these patients specifically, that if you define success as a healthy mother and healthy baby, even in the very highest risk of cases, it was safer to reduce to a singleton than keep the twins. This was combined with an increasing recognition that the risks of twins were not as trivial as people had imagined them to be. So the debate about going from 2 to 1 really started from the debate about with triplets or quads, should you go down to 2 or could you go down to 1? And what we found was in patients going from 3 to 2, and actually this study, the first author was by Yuval Yaron, who works together with Liran, is that if you went from 3 to 2, you actually had a higher total take-home baby rate, but a high prematurity rate. And what we noticed was there was about a 1% loss of the second twin, of one twin in the second half of the pregnancies. Now, if you go from 3 to 2, if you lose 1, you feel terrible, but you still take home a baby and everybody declares success. If we go down to a singleton, we don't have that margin for error. And so we were seeing a slightly higher loss rate, but a lower prematurity rate in surviving pregnancies. And therefore, to go from 3 to 1 requires going through 2 to 1, and this is where the scientific and ethical debate began. What we now know, and these are in several tables in the papers that we've have in the series, going from 2 to 1 cuts the loss rate, prematurity, and morbidity by more than 50%. We have also found that we do genetic testing on about 85% of all the patients, and then use that in the decision as to how to reduce. Now, the way that we decide what we're going to do and what we're going to keep is, first of all, do I find a problem? If not, am I still suspicious about something? Just the same way as all of us at work every day of the week, and I say this is what I say to patients, look at situations that are technically normal, but sometimes you just don't get a good feeling about something. Well, guess what? So do we. Now, the genetic testing has also gotten more sensitive in that we now do a microarray analysis on about 80% of the patients. And I'll come back to that data in a minute. But in terms of gender, when we first started this, we would not even consider gender because we didn't need the extra ethical problem to be compounded on top of everything else. And also what we found back 30 years ago, this may not be politically correct, but it was the truth, is that the vast majority of requests for gender preference came from couples of traditional Asian, Arab, and Indian backgrounds, frankly, all of whom wanted boys. And we didn't, I've always been a big believer in prenatal diagnosis, but being a girl is not a disease. And so therefore we wouldn't entertain it. What we have seen now over the past years is that now we see preference for gender coming from all ethnic groups. And the critical point is patients are just as likely to want a girl as a boy. And in couples reducing to twins, they mostly want one of each. And with John Fletcher's help before he died, we made the transition to being willing to do that. So overall, about 1/3 of our patients are 2-to-1 reductions. Most are over 35 and want genetic testing. Our patients coming locally, typically we get the FISH overnight and then the karyotype. And the local patients will wait for the microarray to come back. But before COVID, about 80% of our patients came by airplane. Now it's about 50%. Most of them coming by airplane will reduce based upon the FISH results alone. Overall, and this is consistent with Liron's talk, is we get a vast reduction in loss rate by going from 2-to-1. And in fact, we have noticed, although this we have not looked at rigorously in a long time, it seems that the outcome of our singletons is actually in some respects better than a singleton, because to some degree, we are able to decide which of the two fetuses looks better. And while it's not perfect, combined with the genetic information, we seem to have a lower risk of poor neonatal outcomes. And the gender preference, frankly, has been 50-50. So the question, we'll save this for later. Okay. Thanks so much.
Thank you, Mark. Controversial as always, and looking forward to some animated discussion from your talk.
Well, rule number 1, John, is if you don't keep the audience awake, it doesn't matter what you said.
Well, I'm sure some people are sitting up there, so we'll talk more. So thank you. Okay, our next talk. Thank you very much, Mark. Our next talk, and thanks for keeping to time. We're going to try and leave some time for questions. And apparently, after an hour, we turn into pumpkins or something like that. So I'm going to promise Vincenzo I'll do my best. So Maeve, you're around the corner from me in Cleveland. Why have we not met each other more? Maeve is Division of Maternal Fetal Medicine, OBGYN, at the Cleveland Institute, Cleveland, Ohio. Just down the corridor from me, across the road to Buffalo, and turn right. So hope to see you more after this, Maeve. And we're going to talk about screening for aneuploidy. Thank you very much.
Thank you, John. And it's such an honor to be on a panel of such distinguished guests. I am partially representing my better half, Lorraine Dugoff, my lovely mentor and friend. I'm going to discuss aneuploidy screening in twins. First of all, twin pregnancies, they do present unique challenges for aneuploidy screening. And it's important to remember that there is no single method for aneuploidy screening that's as accurate in twin pregnancies as in singleton pregnancies. In twin pregnancies, risks are related to maternal age as they are with singletons, as well as twin zygosity. Pretest counseling is important in dizygotic twins and monozygotic twins. The dizygotic twins, pretest counseling considerations include that each twin should have independent risk for aneuploidy. That's not always the case depending on karyotype if diagnostic testing is available. Some studies show that diagnostic testing may confer a higher risk of loss compared to singletons, although, as we heard from Mark, if this is being used to drive reduction decisions, it may actually lead to more positive outcomes if there is invasive or diagnostic testing performed. In monozygotic twins, each twin should have equivalent risk of aneuploidy, but I think it was Lisbeth who pointed out that there are reported cases of aneuploidy discordance in monozygotic twins. Because of the presumed karyotype concordance, serum analytes may be more accurate in monozygotic twins than in dizygotic twins. And some studies have shown lower than expected rates of aneuploidy compared to singleton pregnancies based on maternal age in monozygotic twin pregnancies. And again, the consideration of diagnostic testing and the risks of diagnostic testing, whether that would be pursued if screening returned positive. Aneuploidy screening in twins, I apologize, this is projecting not how I intended, but nuchal translucency is an option, a simple first trimester ultrasound to screen for aneuploidy in twins. That shows a detection rate around 69% with a false positive rate of 5%. The first trimester screen that combines nuchal translucency with PAP-A and HCG, that will improve the detection rate to 89% with that 5% false positive rate. The first trimester screen is theoretically better performing in monozygotic pairs than in dizygotic pairs. Serum integrated or second trimester screening, there are limited data on the performance of second trimester serum screens. Detection rates for trisomy 21 reported on the literature vary quite a bit, from 41% to 90%, and again, may be more accurate in monozygotic pairs. Currently, self-read DNA appears to have the highest detection rate, and that's very supported by literature, particularly in the past several years. The detection rate for trisomy 21 is estimated at 99% for self-read DNA aneuploidy screening, with a low false positive rate. 0.02 is from a recent meta-analysis for a false positive rate. There are limitations. While self-read DNA does appear to be the best aneuploidy screening option for twins, limitations include a fetal fraction consideration. One prospective study suggested that in twin pregnancies, the median fetal fraction was lower than in singleton pregnancies, 8% compared to 11%. And a recent large prospective study that was presented at SMFM by Dr. Dugoff showed a 4% non-reportable result rate in twin pregnancies. However, 64% of these patients did have a reportable result with a second blood draw. And the average gestational age of blood draw in Dr. Dugoff's study was quite early, around 12 weeks, indicating that this is an fairly accurate, acceptable study for aneuploidy screening in the first trimester for twins. Given the small number of affected cases, it's difficult to determine the detection rate for trisomy 18 and 13, although the recent study that Dr. Dugoff presented at SMFM did show detection of all 10 cases of trisomy 18 in that study. Cases of early spontaneous reduction of singleton pregnancies, referred to sometimes as a vanishing twin, do present a unique challenge to self-read DNA screening. It's estimated an aneuploidy rate of around 60% in the co-twin, the vanishing twin loss, which can complicate interpretation of self-read DNA results. There are active studies underway looking at SNP-based arrays to assess aneuploidy risk in the surviving singleton when a vanishing twin is detected by ultrasound. So in conclusion, aneuploidy screening and pretest counseling in twin pregnancies can be complex, and zygosity and maternal age and willingness for diagnostic testing needs to be considered. Self-read DNA screening appears to have a high detection rate, although there are some limitations, and all providers should be familiar with the overall risk of aneuploidy screening options that are available and their risks and benefits. Thank you.
So I just got a message from John that his computer froze and he can't unmute. So I hope it can be as elegant as you, John. Our next presenter is Amanda. Amanda is an associate professor at the Division of Maternal Fetal Medicine, Department of Obstetric Gynecology at the Sidney Kimmel Medical College at the Thomas Jefferson University from Philadelphia, and she will talk to us about preterm birth in twins. Thank you, Amanda.
Thank you, Amir. Thank you for the invitation and the invitation to participate in this wonderful supplement. And I'm very honored to be here with these worldwide experts. And so I'm going to talk about preterm birth in twins. I tell my patients that twins are troublemakers, and all the way through from maternal and fetal reasons. So the major problem in twins is preterm birth. If you look at singletons, a singleton has an 8.2% risk of preterm birth before 37 weeks, but in twins it goes more than 10 times to 60%. And if we look at extremely preterms less than 34 weeks, it's also very high at 20%. So it's a real problem. And when we have explored, everybody thinks it's just twin-to-twin transfusion syndrome and genetics and growth. But if we explore these incidents of what spontaneous onset of labor, it was 60% of the 60% of all preterm birth deliveries, and it was higher in the monochorionic diamniotics than in the di twins. So spontaneous labor is a major problem. For many years have been diagnosed that the cervical length is the most important tool to diagnose preterm deliveries, and the shorter the cervix, the higher the risk to deliver. And in this study, it showed like the less than 28 weeks, which is extremely preterm delivery, is about 4%. When we look at the cervical length, I like this study very much, and I included in my publication. It's a study that includes all randomized trials, control groups, and observational of the gestational age when the cervical length was done, and how long the cervix was, and prediction and the probability of how many patients are going to be delivered before time. So the conclusion is that the shorter the cervix and the earlier the gestational age diagnosis, the higher the risk of preterm delivery. So we identified the problem. And then is there a difference between monochorionics and diamniotics? So we review as well this question, and we identified that monochorionics have shorter cervix and they deliver earlier as well compared with the dichorionic pregnancies. And also pregnancies after IVF treatment, they also have the tendency of higher incidence of short cervix and higher incidence of preterm delivery. Therefore, who are at higher risk? Twins with shorter cervix at earlier gestational age who are also monochorionic and IVF pregnancy. Then we identified the problem, and in the second part of our publication, we evaluated all the prevention of preterm birth in twin pregnancies, all the studies that have been published, and we explore the progesterone supplementation, are they intramuscular or vaginal, pessary and cerclage in different moments of pregnancy, first trimester due to short cervix, or physical exam indicated cerclage. So in summary, the progesterone in twins, in unselected twins, did not work and is not recommended. Twins with cervical length less than 25 millimeters prior to 24 weeks, the intramuscular progesterone did not work. The vaginal progesterone is associated with a reduction in preterm birth in some studies, but most importantly, reduction in the neonatal poor outcomes. And the events study that started the progesterone very early also showed that twins with short cervix had a better outcomes with vaginal, with progesterone supplementation. So we still use it in our practice. Twins with history of preterm delivery, there are no studies and we don't have data at this time, which is a very important set of group that we need to study. In terms of pessary in unselected twins, it's not recommended, it didn't work. And in twins with short cervix, there is a cubical result. Some studies, randomized clinical trials have showed great benefit to decrease preterm birth, but some others showed the opposite with no benefit. It may work better in twins who have a longer cervix between 15 to 25, 30 millimeters, but not in a very short cervix. Then let's explore to the cerclage. I'm going to go a little bit backwards because of the publication of the randomized clinical trial we developed. We identified the patients for our study mostly from the ultrasound unit. Most patients were very short cervix, and at the physical exam showed dilated cervix with viscous membranes, or we diagnosed them with dilated cervix in the transvaginal cervical evaluations. Few patients were diagnosed in clinic. Two of them where they were doing pap smear or pelvic exam. So if you only do physical examination, you're going to miss a lot of patients. Then these are the results of our randomized clinical trial with twins with dilated cervix and physical exam indicated cerclage versus no cerclage. And there was a significant decrease of preterm delivery at all gestational ages. The interval from diagnosis to delivery was prolonged by 5 to 6 weeks. And the delivery less than 2 weeks was decreased by 70%. And most importantly, it decreased the overall mortality by 70% with a number needed to treat of 4. So this is the most important treatment for patients with twin pregnancies and dilated cervix to decrease preterm birth. How do we screen our patients? And we are currently doing a randomized clinical trials of twins and short cervix less than 15 millimeters before 24 weeks. So we screen all our patients from 16 weeks to 24 weeks. If they have short cervix less than 25 millimeters, we offer them vaginal progesterone. If they have less than 10 millimeters, we do pelvic examinations. If they dilated, now we change our practice and offer them cerclage. If they're closed, then they go to the randomized clinical trial to either cerclage versus no cerclage and continue the vaginal progesterone in both arms. This study is having a very slow enrollment, and we need your help to be an enrolling site to be able to finish this study soon and have more answers for you. These are the summary of our publication in interventions of therapies with asymptomatic twin pregnancies. So bed rest is not recommended. We want the patients active. More problems are coming due to bed rest. Tocolysis are not recommended. The progesterones intramuscular did not help. Vaginal progesterone, we continue giving it to patients with short cervix, less than 25 millimeters. And in terms of cerclage, we only have a strong recommendation from the dilated cervix, and we'll continue working on our randomized clinical trial. Some questions I always get asked are about our RCT is regarding the combinations of cerclage, progesterone. We few patients got the progesterone and had no differences, but definitely better than cerclage and progesterone with the progesterone alone. And the combo, you have to remember this RCT was cerclage, indomethacin, and antibiotic at the time of placement versus indomethacin alone. So indomethacin alone didn't help. And the last thing is the moment when you place the cerclage. So even if you place the cerclage very early and you identify the dilated cervix very early, it still will decrease a lot of perinatal mortality in this early diagnosis, or if you have a dilation more than 2 centimeters, again showed that an interval from diagnosis to delivery was close to 9 weeks. Thank you very much.
Thank you, Amanda. And I'm glad that I managed to sort out my technical issues to come back and listen to you. You've been leading the world in this. And I think you've done such a good job that we've lost our equipoise, which is why we're having such a trouble recruiting already. But I think your work is excellent, and thank you for that. So our final talk, Amir. Amir is a maternal fetal medicine specialist. He's an associate professor at Sunnybrook, where I worked for many years in a twins clinic before my move to McMaster. And it's really because of Amir that I think we're here today. From his pulled us all together. So it's good that you have the last word. And I think the last word is, all these twins have to be delivered one day. So let's talk about mode of delivery and multiples. Thank you, Amir.
And thank you, John, for presenting me. And I want to thank Vincenzo for letting us do whatever we wanted with this issue. And thank you for all of our collaborators that tolerated our countless emails back and forth. I knew I'm going to be last, so I promise I have only 5 slides and it's going to be super fast. So just go to the AJOG MFM website. It's open access, and read the manuscripts. They're all there. But when we're talking about mode of delivery in twins, we really have to talk first about timing of delivery. And then we need to talk about the mode of delivery. And at the end, we need to talk about the mechanism or the setting of how we're going to manage the delivery. And that actually has 3 fundamentals that we need to consider. And the first is the skill, the expertise, and the resources. Because if we don't have an ultrasound, we can't use it. If we don't have an anesthesiologist on the floor ready to give us a hand when we need to, then we can't really consider all of our options. Chronicity plays a very big role, and of course, the presentation of twin A. I'm sure all of you read John's study, this huge multinational, multi-center study, the TBS, about the mode of delivery in twins. It was the biggest and only RCT about that. And then the presentation of twin A really plays a lot of difference in it. So in terms of chronicity, if we're dealing with monochorionic twins, as Tim suggested, then we need to deliver them at around 32 to 34 weeks of gestation. And regardless of the presentation of twin A, we're going to do it in a C-section, just because we're scared of all the entanglement, cord entanglement complications. As for monodiag twins and didag twins, it's a little bit different. So for monodiag twin, we want to deliver them anywhere between 35 and 37 weeks of gestation. And for didag twins, maybe 37, 38. And I know that different societies give different thresholds. I think the American College of Gynecology states that for monodiag is 34 to 37. The NICE guidelines state 36 to 37, but roughly all of them are speaking around the same time range. And then if twin A is vertex in both of these cases, both in monochorionic diamniotic and dichorionic diamniotic, then yes, we can do a trial of labor regardless of twins B presentation. But if twins A presentation is non-vertex, then we need to go to a C-section. And I think all of us do that just because we extrapolate from Mary Hannah's term breech trial, and we don't do breech first twins anymore. In terms of the mechanism of or how we should do it, then the first questions that we should ask ourselves is first, if the personnel experienced in vaginal twin deliveries. Is twin A in vertex presentation, and did we rule out any contraindications for vaginal delivery, such as placenta previa? If any of these questions deserves a no as an answer, then we have to proceed with the C-section. And then if we decided to proceed with the trial of labor, then epidural anesthesia is really recommended, especially because if we need to convert to a C-section, if we need to do any kind of intrauterine manipulations for twin B, it's easier when the mom has adequate epidural anesthesia. IV access, obviously, again, if we need to transition. Lab work, CDC, and group and screen can be very helpful if we need to transition to a C-section. And then consider continuous fetal heart rate monitoring and a scalp clip. A scalp clip is very helpful in distinguishing twin A for twin B. Assuming everything went well until this point, then, if we have a non-reassuring signs of fetal well-being, of course, we proceed with the C-section. Assuming everything went well until this point and the patient is ready to push, we advocate for double setup, which means doing the delivery even in a trial of labor in the OR, just again in case we need to transition fast to a C-section. We know that the longer it takes us to do a C-section, the worse the outcomes. So if we do everything in the OR, then we decrease significantly the decision to incision time if need be. After the delivery of twin A, we need to establish the presentation of twin B, preferably with ultrasound if we have one. If not, then of course vaginal examination is good enough. Assess the cervix, administer oxytocin, and assess the well-being of twin B. And obviously, if there are any signs of non-reassuring fetal heart rate or fetal well-being, we proceed with the C-section. If twin B is in a non-vertex presentation, then the preferred method is internal podalic version and total breech extraction. There are several studies that show that external cephalic version is inferior to internal podalic version and total breech extraction, both in terms of outcomes and in terms of success. If we don't succeed in delivering twin B, then we proceed with the C-section. And we have to remember that after the delivery of twin B, still we need to actively manage the third stage of labor in order to decrease as much as possible the risk of PPH. Thank you, everybody.
Thanks, Amir, for that succinct discussion. So I wish to say that Vincenzo has said that we can talk, because how often do a group of investigators and colleagues like us get to sit and spend 15 minutes talking about the way we spend our lives? I think it's a gift. In fact, I'd like to have another session just with discussion and just the opportunity to sit down with Elizabeth, or Tim might get a chance to, although not really. We live, like, our hospitals are 30 minutes apart. But when's the last time, Tim, we actually sat down and actually spoke about this kind of stuff? And to talk with Mark about all the controversial stuff. I think Amanda trying to get pickled. I'm going to start off the discussion. So in 1996, when I came on faculty, my then chairman said to me, "What do you want to do?" I said, "I have no idea." He said, "Well, you have to find an area that's interesting and that's important." So I said, "Well, it's all interesting and important." He said, "Why don't you look at twins? There are a lot of them around, right?" And so I think the only people around who were at that, Mark, you remember when this all started, maybe Vincenzo, but he always looks young, so I know how old he is. But yeah, Mark and I were remembering when this happened, right? All of a sudden, these twins came from nowhere, an explosion. I've been on record as saying it was an epidemic. Epidemic's a bad thing. A pandemic of twins. It is. It's a pandemic of twins, and their outcome is I wouldn't say it's awful, but it's worse than singleton. And I thought, okay, this is easy. I'm going to start a multiples clinic, which I did, the first one in Canada. And I thought it'll be easy. We'll just send multiples clinics across Canada, because twins have the highest rate of complication of any complication, probably except abruption. And it failed. I was the only center, it's still probably the only center. So the discussion I want to have is, from everyone we've heard, why do why do all obstetricians look after twins? And why do we not have in all our countries, and maybe you do in Europe, I don't know, maybe you do in the States, I don't think you do, have all twins, never mind the high-risk ones, the fancy ones that Tim sees and Elizabeth sees and the monoamniotics, all twins in specialized clinics dealing with all this stuff. So I'd like that discussion to start off with. And maybe somewhere, I don't know, maybe from Europe, what happens there? And what do you think about that, Elizabeth?
Yeah, I think in the UK they already have guidelines about that twins should be followed in dedicated clinics where also there's social support and a dietitian and a physiotherapist and I think for patient care alone it's a bonus. I think the expecting twin mothers deserve a dedicated twin clinic.
Yeah. Maeve, Mark, that doesn't happen in the US. I know it doesn't happen. I know it doesn't happen in Canada. We have midwives, obstetricians looking after twins. I know it doesn't happen in Canada. What happens south of the 49?
In the States, it's a free-for-all. And in a few places, there is some coordination and regionalization of care. But in a lot of places, it's this every man and woman for himself mentality that we're seeing in our politics these days. And that there's a total lack of appreciation of sophistication or prioritization of care. I mean, there are some places like the Mayo Clinic that have a model as to who can do what. But for most practices around the country, it is a complete free-for-all. And unfortunately, I believe our whole process of triage has been backwards. And even before Kipros published his inverted pyramid, we had published the idea that the role of the subspecialist was to lead, follow, or get out of the way. And what I believe is that everybody should have a higher level of screening with triaging downward for the vast majority of patients, rather than having the least educated person deciding who needs to be triaged upward. But the only way that will be solved in our system is by having the insurance companies start paying for better care and deducting for worse care. That will get people's attention. It doesn't matter how you tell people they should be incentivized. It's how they really are incentivized, which determines what they do.
Thanks, Mark. Maeve and Amanda, any comment from your part of? One thing I have learned is there's no such thing as the US. Practice can vary very.
Yeah.
So what's in your area? Has the concept of twins focused that it's really a high risk complication, or is it still one of these things that everybody can manage?
I think at large academic centers, sometimes chorionicity, there may be a specialized clinic available for monochorionic twins, but that needs to be in the United States generally at a large academic center, and there's a lot of regional disparities in delivery of care, so that's not available to a lot of patients in the United States. Amanda?
Yeah, the same. So everybody is always so happy to have instant family, infertility treatment forever, and then you have now twins and everybody's so excited, but they don't know what they're getting into. I always start my clinic and my speech with patients to tell them twins are troublemaker, just to get an idea of how bad they can go. They can go bad from the ultrasound point of view, from the maternal physiological changes, adaptation to twins, just going to third trimester with 2 babies, multiple appointments, trying to work with twin pregnancy, and now they delivered twins, and if something bad happened, short cervix, twin-to-twin transfusion, fetal growth restriction. It's just too much for one single woman and for a family to get these twins, and everybody's so excited, oh, twins, and then they're born and then they're crying all at the same time. It's just too much emotionally, physically, and medically, that people don't know what they're getting into.
I think that's right. Liran, I mean, we've just rewritten the Canadian guidelines, and I think we had a paragraph on twins clinics, didn't we? But I think even there we shied away from the recommendation that all twins should be seen as specialized clinics, because we wouldn't have had support. We would get shot down by our colleagues to say, I'm an obstetrician, I can look after twins. We wouldn't have got that. Even to refer all twins for consult would, and yet, I think I'm right in saying, because I say this to my students, so I better be right, that the risk of being just a twin, and I'm talking about a dichorionic twin, right? is as high as any of the other high-risk clinics that we routine. I mean, no one thinks twice of having a clinic for gestational diabetes. No one thinks twice of having a clinic for IUGR, right? But if you look at this twin-specific risk of just a twin, the risk of being just a twin is much higher than gestational diabetes. I mean, the relative risk of gestational diabetes for neonatal outcomes is about 1.2 compared to the 1 of a singleton, whereas twins about a 9. And yet we are shying away from making the recommendation we all agree, probably because we're stepping on too many people's toes. Liran, what happens in Israel?
So actually, we don't have a specific link in all centers. In my center, I'm handling the twins clinic, but maybe this is because of you mentored me for a few years, so I'm getting the vibes there, and I'm familiar with this area. And I think we have most of the clinics are usually focused on the monochorionic twins because of the ultrasound surveillance. But I think the importance, in this event is to get the notice of people and to raise this important concern that we should have, because there's many complications, not just the growth and not just the TTS and the TAPS and everything, but also the what we call the low risk twins. How can you say that in the same phrase, low risk twins clinic?
It's an oxymoron, isn't it? Mm-hmm. I remember, and there's not one randomized trial. There are a lot of cohort studies looking at the outcomes of twins clinics. All of them show an improved outcome. The trouble is they're very biased. Do you guys remember Barbara Luke? So Barbara was one of the forerunners of twins clinic, very into nutrition. And she saw very clearly, if you look at the early data, that twins in a twin clinic did better. The trouble is, her cohort wasn't matched for dichorionics and monochorionics, so not a very robust thing. But I think that's true. I'm going to switch the discussion now to the monochorionics, and maybe Elizabeth and Tim, let's have some discussion. They drive me crazy trying to work out when to deliver the type 3 SIUGR, and watching these reverse flows and doing nothing, and then in the back of my mind, my sneaking suspicion and clinical reality is that patients that I refer to Tim, for twin, and he sends them back to me and says, absolutely not. And we manage them or not. And then all of a sudden they are, because there's this overlap that we've all seen. How do we sort those ones out? How do we sort out the mixed twin IUGR? Because I promise you it exists, and I still haven't got an answer of it. Who wants to take that?
I'm happy to start off, but I'm sure that Lisbeth will kick in. The big problem is that we don't have a crystal ball, and that is certainly something that we should invest in, is trying to develop a crystal ball for monochorionic twins, because they can do really very well for a long time, and then all of a sudden over the course of a couple of days, sometimes even, develop these very acute conditions, and that is really one of the big problems. I think we've tried to look at all kinds of possible predictors for twin transfusion syndrome, looking in the first trimester at increased nuchals, abnormal ductus venosus, size differences, all these kind of things, and then later in pregnancy looking at cardiac function, and all these things. But unfortunately, we still haven't found the one predictor that really allows us to predict which ones will turn into twin transfusion and which ones will not. And that comes with a high cost to society, because that now means that we need to follow all these pregnancies with ultrasounds every other week, which is not something to be underestimated financially, and which is not something to be underestimated also from a patient perspective of the need for coming in all the time. But I think that the first step into finding this kind of, or one of the crucial steps into finding this kind of crystal ball will be to better understand why twin transfusion syndrome happens. And we know that the anastomoses in the placenta play a role, but why all of a sudden at 20 weeks they go bad? And why? Because those anastomoses were there at 16 weeks, and why do they not? Why is there no twin transfusion syndrome at 16 weeks, where at 20 or 22 weeks all of a sudden it's so bad? And then the different subtypes of twin, as you say, there is some that overlap with IUGR, there is some that are pure fluid discordance. There is some that start with abnormal Dopplers and then go to fluid differences. It's still a big mess, and I think understanding the pathophysiology will help us much there. But
Elizabeth, any comment to add?
Yeah, no, I mean, I agree with Tim that as long as the babies are connected to the placenta, then everything can happen. And I think for selective fetal growth restriction, I mean, it's rare that they develop TTTS once you get, above 26 weeks. But there you're concerned about acute intertwin transfusion and demise. And that's the difficult thing, I think, especially in the type 3 cases where we have decided once they are 32 to 34 weeks that it's better to deliver them because you cannot predict these acute intertwin transfusions and you risk losing both twins.
Yeah, that's certainly a challenge. Okay, who wants to take on Mark? Mark's suggesting we spend our career saving twins and he wants to make them singleton. Who wants to take on Mark? See, Mark, I'll take you on because
Okay, that's fine.
the trouble is you need to do a randomized trial if you can, because the trouble is you're selecting those ones that you're reducing to the singletons, because you just said it, you've got this gestalt, and I believe you do. When you've got that probe in your hand, you get that gestalt, and then you're selecting these really excellent patients, the type of patients you're selecting for the reduction to singletons. You're selecting a really high a positive outcome singleton compared to the average. But to do a randomized trial, I don't know if you'd ever be able to do.
Not going to happen. We're 30 years too late for that.
Yeah.
And first of all, we're not selecting the patients are selecting us.
Yeah, that's the point. That's why your results are always going to be a bias towards a good outcome in those that get reduced, right?
Well, it also goes back to the center of excellence issues that we alluded to earlier. 30 years ago, Kentucky Fried Chicken used to have a campaign slogan, do one thing and do it right. We can certainly quibble about the chicken, but the concept was correct. And I think one of our problems across the specialty is we have too many people doing stuff they're really not good at because they don't want to pass it on to somebody else for financial and ego reasons. And that's one of the reasons for the massive expansion of NIPT is it allows a lot of practitioners to not have to refer patients to the fetal medicine center for evaluation, which is fine until things go bad. Right. And then when they go bad, things are, it's all that much worse. I believe you also have huge variations in patients' requests, demographics, as more and more women are, 40 years ago, the average 40-year-old woman who was pregnant was a woman who'd been married for 20 years, having her third or fourth kid. Today, it's a professional woman having her first child. And the way that these patients approach the pregnancy can sometimes be quite dramatically different. And I think we have to be sensitive to that there are a lot of people who simply do not want to have the burden of having twins at once. I've always said to my parents, 2 adults, 1 kid, fair fight. 2 until you're hopelessly outnumbered. 3 or more, you're playing zone defense. This I say as a parent, not as a physician. And our whole society has changed to have and has to be recognizing that this is the new reality, and we have to be appreciative of it.
Thanks for that. Let's on to preterm birth. Okay, I mean, 80% of all our perinatal morbidity and mortality is because of preterm birth. It's the most. Monochorionics and that are really exciting and fancy, and the laser that Tim does is all. It's amazing stuff, science fiction. But really, the bread and butter of what we do is preterm birth. Amanda, I don't know. We had several discussions about us in Canada joining your trial. I don't know about you, everybody on the call here. I'm convinced it works. You'd have to convince me really hard to take a cervix that I'm watching progressively get shorter. That's now 1.5 to randomize. So I'm all for randomized trials, as you know. But what does everybody think? Do you think like Mark that it's flown already? But I don't know. What do you think?
We really want to bring more information on a randomized clinical trial to convince everybody. So one of my goals 10 years ago, when I saw AJOG put in a statement saying cervical lengths, don't do cervical lengths in twins because we don't have treatment. Don't do surclasses in twins because it will increase harm. And I was like, that's not what I'm seeing doing my fellowship and doing surclass in twins. And I actually had to convince seriously Dr. Bergera to start doing an RCT because the first statement was no surclass in twins. So I've been working on this for 10 years, and he told me 20 years to get his class studies done, and I'm into my 10th year. So it's a long road to convince the community that it's a possibility that class works. So it's a slow. The study that we're doing required 200 women to be enrolled in the trial. We're up to only 22 patients being enrolled after 3 years. Then we have COVID, and we don't have sites that want to enroll because we don't have grant for a study. We have been trying to get one, but it's difficult. It's not a fancy topic. Clash in twins. So it's just out of love that we're doing this study, but we need to continue working on this and present the data to the world to convince that class will not cause harm and it will potentially help in extreme circumstances. So we did the first study with dilated cervix, and we changed our practice in 2019, have done about 20 class, 20 patients, most of them referred from other places, and we have seen good outcomes. Of course, we cannot save everybody. There are cases that are too advanced, already had chorioamnionitis, despite the surclass, still going to labor within few days, a week after the procedure is done. A lot of women decline the amniocentesis, and amniocentesis is not either a perfect test. So it's very difficult when you have the patient in front of you who had years of infertility, got pregnant, got normal genetics sometimes, and now I have an open cervix or short cervix, and you're telling me that there is nothing to do. It just strikes me as very bad. Like you're working on these patients for years and years, and now we have short cervix. So we need to have this RCT finished as soon as possible.
I agree, and everybody who's listening, if Amanda, I'm sure that you'll be willing to talk, and I'm sure we could do better in Canada. You don't have to convince me. We've just published a series of, I think there were, 9 or 10 patients of advanced cervical dilatation, up to 7 centimeters, amnio drainage, aggressive. And I just never forget the one lady that she was, I think, 7 or 8 centimeters. Infertility.
I remember this case, John. I remember this case.
Yeah, we had,
I said, okay, John. I remember this case. John said, okay, let's teach her up, and she we gave her the most important few weeks, because if you get it through early prematurity, then in most cases it will be fine.
Yeah, and then we did some of the fluid, and I wish you would have had some better sort of interleukins and stuff, but she was at least 7 or 8 centimeters, and I think she went from 22 weeks, I think almost to 28 or 30 weeks after the stitch, and she wouldn't have done that before. Final word, we're running out of time. We could, as I say, we could just talk about this all time. Amir, so, you mentioned the twin birth study. So I spent 10 years of my life and $9 million of Canadian taxpayers' money proving that planned vaginal birth is as safe as planned cesarean section. Was it a complete waste?
No, I don't think it was a complete waste. I think that, like a lot of things, it takes paradigm shifts and generation changes before things change. I think it takes back to what Mark said previously about how things change along the time. And if you look at the term breach trial, it was preaching to the choir, right? Everybody wanted to stop doing breaches, and then came a study that said, well, you shouldn't do breach. So everybody were happy, even though the study was completely flawed in some ways. And then for the TBS, I think everybody were kind of hoping that it would show, yes, let's do C-sections for everybody, and it didn't. So it kind of messes up with everybody's plans, essentially. If you look at what Tim was trying to do with the monochorionic study, that he was trying to show that if you do good outpatient surveillance, it's as good as doing inpatient, but still everybody are doing inpatient for some reason, except for Mount Sinai, and they should be doing outpatient good surveillance. So again, I think it's generational shift, it's paradigm shift, and it's getting the studies out that actually measures what people think they should be. So I don't think it was a waste of time. I think it's very reassuring for some patients to know that picking a vaginal delivery for twins is a good decision. Those who are opting for C-section, or those physicians that are preaching for C-section because it's easier for them, that's a different story, right? That's politics and geographic, not necessarily science.
Yeah, I think if we can get, otherwise it drives me completely crazy when indication for cesarean section, twins, right? They are not an indication for cesarean section, but I guess now maybe we haven't had time.
Look at the TBS. Even in the TBS, if you look at the appendixes, the reason for a C-section, the physician was uncomfortable. So why did you enroll in the study?
Right. Maybe we haven't had time to talk about screening in twins. It's a very interesting topic. I mean, when I started this, there was nothing we could do with screening, and now, thank God, with an IPS. And you made a great point about discordant abnormalities. Was it Elizabeth? Somebody said it. So I think that's an important point. But I'm getting sort of alarms here. We've run out of time. I still think we could have this again, just a discussion point, because there's just so much to talk. But Vincenzo, you told me not to go over time, so thank you for facilitating this. It's been probably the most enjoyable hour and 15 minutes I've spent for a long time. I hope maybe, I don't know, if we all travel again, we can meet at SMFM or ACOG or somewhere, Fetus as a Patient in Europe, somewhere nice, and we could twin studies, the twin conference, somewhere like that. Let's do this again. Vincenzo, thank you very much. It's a wonderful opportunity.
Oh, thank you, John. This was great. I actually agreed with everything said, and I'm going to watch it again. I watched every second. It's really informative. There's a lot of information here. So thanks, Amir. Thanks, Amanda. Thanks, Liran. Thanks, Lisbeth. Thanks, Mark. Thanks, Maeve. Thanks, Tim. And again, this was a special issue at AJOG MFM. A lot of work, especially for John, Amir, and all of you. And I also want to congratulate the ones of you who have done incredible trials, trials that people thought they were never going to be done. The twin delivery or the delivery trial. I mean, when I read that, and I knew it was going on for many years, I just my heart sprung with joy. And then Amanda, two very difficult trials you have done and you continue to do. So I can't thank you all enough. I just want to tell people again that they can watch us, as I said at the beginning, on Twitter, YouTube, and AJOG MFM, and on Facebook, Twitter, and YouTube. And I thank them for joining us. Come back again next week. We'll start doing some of the labor management series, preparation before labor. We'll probably touch on vaginal progesterone versus 17P later in May, and also start doing inductional labor and other topics. Again, it's great that so many of you join us. And again, thanks, John, and all our friends here. And see you next week. Thanks, everyone.
Bye-bye.